Wow. Head. How incredible is it to have a governor that is so dedicated and so invested in the health of our pregnant moms across the state and our newborn babies?
It's really pretty incredible. I know that he wanted to be with us here today to talk about these new initiatives and also to share in the content of an incredible conference. Thank you so much for being here. It really is extraordinary to look across this room and see all of you here for this 6th annual conference.
My name is Dr. Kris Box, and I've been the commissioner for the Indiana State Department of Health now for just over a year. And prior to that, an obstetrician gynecologist for the past 30 years plus.
And I'm Dr. Jen Walthall. I'm the secretary at the Indiana Family and Social Services Administration. Have been in that role for nearly 2 years now, and I'm a pediatric emergency medicine physician by training. I still do that. In fact, I worked a shift in the ER last night, and it's those patients and their faces and their families that Dr. Box and I see in our work that helps motivate us to keep working with you to build new initiatives.
So today, Jen and I want to take about 25 or 30 minutes to kind of expand on the governor's 2019 infant mortality agenda and to share with you some of what our teams, what we and our teams at ISDH and FSSA and the Indiana Perinatal Quality Improvement Collaborative have been doing. As the governor just said, he wants to focus on 2 specific areas with his agenda. First is making sure that we attach an obstetrical navigator to every at-risk pregnancy going forward. Also, to make sure that every provider that is giving obstetrical care as early as possible in pregnancy uses a validated verbal screening tool to screen that pregnant woman for substance use disorder. I want to take a moment just to set the stage about why these 2 programs are so important and how it's important that we roll these out across our state. Based on our 2016 data, Indiana has the 7th highest infant mortality rate in the nation. We actually have the 3rd highest maternal mortality rate in the nation. We continue, like many states, to experience significant disparities in our infant mortality and maternal mortality, both racially and ethnically. The governor, as you just heard, has challenged us to be the best in the Midwest by 2024, and you shouldn't throw out a challenge to Dr. Walthall and I because we take it and run with it. This will show you how difficult that task is going to be. This is based on 2016 statistics and shows us all of our Midwest states and where Indiana ranks. As you can see, we're last in the Midwest. But Dr. Walthall and our teams, in combination with you and the IPQUIC committee, I am absolutely positive that we are going to make significant gains in reaching this goal. This shows you our infant mortality rates across the state. As I mentioned, like many other states, we suffer from significant disparities. The blue line here is the Indiana's infant mortality rate overall, with 7.5 deaths per 1,000 live births. The red line is our white infant mortality rate at 6.4. And the black line, unfortunately, has been going up, and that's our Hispanic infant mortality rate at 9. As you can see, the green line, our black infant mortality rate, is running 14.4. So we know that any programming that we develop or any resources we deploy need to be directed toward these high-risk populations. We also break our infant mortality rate down by region. As you can see, based on the amount of blue on this slide, we have work to do all over the state of Indiana, but specifically in our northwestern and our central southwestern districts. Now, the challenges between our urban communities and our more rural communities differ just a little bit. Of our 13 highest risk zip codes, 7 of those are right here in Marion County. That's not an issue of care not being available. It's really an issue of care, these women not being connected to care. And how are we going to connect them to care? In our rural areas, we have 33 counties, a third of our counties, that either don't have a hospital or they don't have a hospital that does obstetrical services. Again, the issue here is how can we get care closer to home? This map shows you those 33 counties without hospitals or hospitals with obstetrical services. So what we'd like to do is to partner with counties like Vigo County or Vanderburgh or Warwick County, possibly Tippecanoe County, to see if we can't hire advanced practice nurses or a nurse midwife that will then go out into the counties surrounding them without obstetrical care and deliver that care closer to home so that we can engage women earlier in prenatal care and more consistently throughout their pregnancy. We know that the Central Southwest area in Vigo County is already doing a form of OB navigation there with their rural health grant. They call it perinatal navigation. So Jen, tell us a little bit about OB navigation, what an OB navigator is, and how we might be able to use OB navigation to connect women to care and bring down our infant and maternal mortalities.
So we know that developing new programs is not always the right answer. In fact, it's generally never the right answer. The right answer is taking a broad look at the services that we have available and connecting them to each other so that we can maximize all of our resources and our efficiency and our effectiveness to build on the goals that we have. So our goals in building this program is to identify our Medicaid moms as early in pregnancy as possible and to connect those moms to an OB navigator using existing services and building them out so that they're available across the entire state to address issues that contribute to infant mortality across the board. Lack of prenatal care in the first trimester, really preventing and managing medical issues like smoking, substance use disorder, prior preterm births that have evidence-based impact that we can deliver more efficiently than we do now, diabetes control, high blood pressure. And then what we really want to get at is the 80% that we know is really about social factors that are unmet. Things like housing and transportation and food insecurity and safety that really become the biggest barriers to women getting the care that they need and the outcomes that we're looking for. And this will allow us to deploy services in communities with limited access to care, and then also to build the connecting bridge to communities that have care already, but women just aren't receiving it in the way that meets their needs. So what in the world is an OB navigator? This is built on, as we did surveys across the country and across the world, evidence-based programs that take healthcare outside of the four walls that we think of in clinics or hospitals and into the places where people live, learn, work, and play, so that health happens where people are, not where medicine lives. These are community-based healthcare providers, such as our partners in Nurse Family Partnership, community health worker programs, community paramedicine, and our partners at the Department of Child Services, Healthy Families, that already are statewide doing prevention services that will just be refocused on the perinatal period. What we'll do is we will assign an OB navigator to all of our Medicaid moms so that they can opt into programs that help them learn how to do the things that they may not know how to do already, and also decrease those barriers to connectivity to care. This will be based on where they're going to give birth so that we make sure that we connect them to their birthing hospitals and they are receiving the services that they want. I'll let you talk a little bit about your safety pin grantees.
Oh, this is awesome. I think you're going to hear from a couple of these programs today, but in Vanderburgh County, we have the local health department there that hired a nurse and community health workers underneath that nurse, and they actually follow women through their prenatal period, through labor and delivery, and then for the first 3 years after delivery, pre to 3, they basically address what kind of education women need during pregnancy, what kind of care they should be getting, following basically through the prenatal time, the delivery time, when babies will basically at that point in time need to be addressed with safe sleep, when we need to make sure that babies are getting their immunizations and that breastfeeding is going well. And we can get women into further education and further job training and help to give them kind of a leg up at that point in time. St. Joseph County did something very similar with their doula program, where they hired to start with 6 Black doulas to get into their community, and they have really been able to expand their program even to other counties up in the northwest part of the state because they've been so successful at that connectivity.
You want to talk about how we're going to get this started? Dr. Box and I would like to, in everything that we do, flip the switch and do everything at once. It turns out that that's not always the most practical thing. And so we're going to roll it this program out over a period of time, starting with some high-risk areas.
So what we did was we looked at those 13 high-risk zip codes and basically took each of those counties and drew a circle around them to make sure that we could address or attack those areas first. Because as much as we'd like to address all 44,500 Medicaid patients from day one when this program goes live, we just didn't have the community health workers, the paramedicine, and the nurse-family partnership to be able to do that. So that's how we're going to get started, and Jen will tell you how we're going to identify these women.
So as you know, Indiana has had 83,000 total deliveries in 2016. 53% of those deliveries were covered by Indiana Medicaid. That's 44,000 Medicaid OB patients. In the 13 high-risk counties by zip code that were identified, we have 18,000 of those births occurring. And so as we began designing this program and roll out as a pilot at the beginning of this coming year, we decided that we would target those areas first and then build services around the successes that we find as those pilots go live. Now, we've already had successes, as Dr. Box said before, in our safety pin grantees, and what we want to make sure that happens is that those successes don't end with pilots, that they really become ingrained in the way that we do business across the state. So we have an incredible data warehouse, and as soon as we have a patient who is covered by Indiana Medicaid that becomes pregnant, she will have the option to take advantage of an enhanced service that will provide that OB Navigator for her to walk her through the entirety of her pregnancy and also through the first year of life, so that all of those risks that are addressed, like safe sleep, smoking cessation, substance use disorder, both recovery and then services that help decrease recidivism, are part of the overall plan. We've seen this work in other processes as well. This is based on the things that we see work in substance use disorder with peer recovery coaches. We do this really well in other disease processes as well. Pregnancy, as we know, is not a disease, but we've borrowed from other kind of Velcro another human being to the person who needs help to decrease those barriers with them in partnership in the community, meeting their needs where they are. This is just a kind of an overview of the process map for how this will work. So the idea being that instead of having a wall or this overwhelming sense of, I'm not sure what to do next at the moment of pregnancy, that we're opening the doors to services and really streamlining how we get moms connected to those things that already exist. So rather than an opt-in to things like nurse-family partnership or community health workers or community paramedicine or our healthy family programs, this will be a direct communication with mom, with our teams working together between Medicaid and the maternal child health team so that moms get early interventions when they need it, and we can blend these services that we have existing and build them so that we move from pilot to statewide in short order.
So the second agenda item for the governor is how can we address perinatal substance use disorder and the resultant NAS that occurs from that. As you know, we've had a significant increase in substance use disorder, more specifically opioid use disorder across our state. We've seen a dramatic rise. And this has really mirrored what we've seen in our general population. So basically, we know, based on national statistics and also our fetal infant mortality review that's been done across our state, that the opioid epidemic, the drug epidemic, is contributing to our maternal and our fetal infant mortality. 44% of Indiana's female overdose victims were ages 20 to 40. That is prime childbearing years. And we know that pregnancy is a very important opportunity, a time when we can identify women with substance use disorder and get them into recovery. Women we know are more motivated when they're pregnant to reach for help or to accept help if we give it at that time, or when they have a new baby at home. And this is why Governor Holcomb supports the recommendation that every pregnant woman should have early universal screening for substance use disorder with a validated tool. And that tool could be the 5 Ps questionnaire that I know many of you probably use, the NIDA quick screen, or even the CRAFT screen. I know that our perinatal substance use task force has been using a version of the 5 Ps, and that's basically where an obstetrical provider partners with the patient to ask the 5 Ps: parents, partner, peers, past, and present. Do your parents, does your partner, Do your peers have a problem with alcohol use or drug use? In the past, have you had a problem with alcohol or drug use or inappropriate use of prescription medications? And in the past month, have you used alcohol or drugs or even prescription medications? Our Perinatal Substance Use Task Force started back in 2015 to address the increasing incidence of neonatal abstinence syndrome, NAS, which all of you, I know is when a baby goes through withdrawals because it's been carried by a mom who's been using substances, most likely opioids, and then when it's separated from mom, it goes through a series of withdrawals. We changed that a little bit in 2016 with our pilot because it was recognized that, hey, we have to go to the front end of this and address women with substance use disorder, get them into treatment, wrap them in a program with mental health services so that we can affect a change in our incidence of neonatal abstinence syndrome. That pilot started with just 4 hospitals and has grown to over 28 hospitals now. And we'll be opening that pilot up for all of our hospitals in the state, and I hope you'll all be interested. In that pilot, we looked at over 7,000 umbilical cords after babies were delivered. And those were babies that were considered to be at risk, meaning maybe mom had a positive verbal screen, or in the past, she had a positive urine or blood screen in her chart, or maybe the baby was born and just didn't look right, showed signs or symptoms of possible withdrawal. And we sent those cords then to test some substances, which I'll show you. The goal with this was to better understand the incidence or prevalence of babies that were being born exposed to drugs. This is the 10-panel screen that Indiana has been using for their umbilical cords. We've also been doing an alcohol test and are changing that in November over to an alcohol spot test. The Perinatal Substance Use Task Force, which is headed by Maria Del Rio Hoover, who is a neonatologist in Southern Indiana. She did an amazing job last year presenting this pilot program and some of our initial data. She and her team have actually developed a toolkit that starts at the very beginning. How do we identify a woman with substance use disorder? How do we wrap her in care with mental health services, a patient care coordinator? How do we get medication-assisted therapy to her? How do we deal with neonatal abstinence syndrome? And then that very important, when they're discharged from the hospital in our care, what follow-up occurs? I wanted to share some of the data from that program that more recently, up till the end of September. As you can see here, Indiana is in the very light blue, and the dark blue is the USDTL lab that we used in Chicago. You can see that Indiana measures higher percentage-wise in opiates in the umbilical cord. I think it's like 12.6% versus 10.2%. We measured higher in barbiturates, and we also measured a little lower in cannabinoids. But what I want you to notice is that almost 18% of our babies tested positive in their umbilical cords in this at-risk population for some form of marijuana. Now go all the way to the right. And what you see there is that Indiana measured significantly lower in buprenorphine, 3.3% versus 7.7% nationally. What that tells us, because buprenorphine is the MAT, or medication-assisted therapy of choice for pregnant women with substance use disorder in pregnancy, is that we're not doing a very good job of recognizing these women in early pregnancy and getting them into treatment. Another way of looking at that data is that these 28 hospitals represented 41,000 of our births. We tested over 7,000 cords, as I mentioned, which was about 17% of those births. What we found is that 40% of those cords for babies that we considered at risk were positive for substances. And we know if we tested every baby that was delivered, these numbers would be much higher. We also had an NAS, neonatal abstinence syndrome, incidence of 10.5 babies per 1,000 live births. And if you extrapolate that out to our 83,000 deliveries every year, we would have almost 900 babies a year being born and going through withdrawal symptoms associated with drug use in pregnancy. So that is why we are supporting, and Governor Holcomb has taken as part of his agenda, early universal verbal screening for every pregnant patient by every OB provider across our state. That gives us the opportunity to identify these women with substance use disorder, to do a brief intervention, to educate them and counsel them about the risks associated not only to their own health with continuing to use these drugs, but also their unborn baby's health. and then to either refer that patient for care, or if we're an MAT provider, which I hope more of our obstetrical providers will become, to actually deliver that care to the patient. But this is only going to work if that initial step occurs, if every obstetrical provider out there partners with their patient to do a validated verbal screen. So Dr. Walthall and I are here today. We're asking you to partner with us in both of these programs to help roll these programs out across our state and to support the governor's 2019 infant mortality agenda so that together we can celebrate more first birthdays in the state of Indiana.
Thank you.
Thank you guys very much.